Hi everyone, welcome to today's webinar. We're going to get started in about a minute or so. We're just going to give people a little bit more time to log on. All right, we're going to go ahead and get started. Welcome to Research Update on Ovarian Cancer. I'm Maggie Nicholas Alexander, Ovarian Cancer Program Director at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a nonprofit organization that has been helping people through breast, ovarian, and uterine cancer for the last 44 years by offering the support of those who have been there. SHARE offers many services, including a helpline, support groups, and educational programs. All services are free of charge to participants. For more information, visit our website at sharecancersupport.org. All participants will be muted during the presentation. When Dr. Long Roche finishes presenting, we will begin the Q&A discussion. You are welcome to submit questions during the presentation through the question pane in the control panel on your screen. When asking questions, remember that the presenter is unable to give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and will be on the SHARE website soon. Now I'd like to introduce our speaker for today. Dr. Kara Long Roche is a gynecologic oncologist in the Department of Surgery at Memorial Sloan Kettering and a member of the MSK section for ovarian cancer surgery. She has a joint appointment at Weill Cornell Medical College. A committed educator, she serves as the Associate Program Director for the Fellowship in Gynecologic Oncology at MSK. Dr. Long Roche has clinical expertise in radical tumor debulking surgery for advanced ovarian cancer. Her research interests include optimizing outcomes for patients undergoing surgery for advanced ovarian cancer, as well as work on screening and prevention, including translational work, investigating novel early detection techniques, and clinical trials in risk-reducing surgery. Welcome, Dr. Long Roche, and I'm going to hand it over to you.
Good afternoon. Thank you so much to Maggie and Vicki and the whole team at SHARE for inviting me to talk about some things that are very important to me, taking care of patients with ovarian cancer and sharing the newest updates that our field has to offer. And I really always enjoy talking with patients. I prefer to see people's faces usually, but in this new era, this is, I guess, the best that we're going to get. I have no disclosures, no financial disclosures relevant to anything in my talk. My only disclosure is that I am a surgeon, so that is my one bias throughout the rest of my discussion. So just to give a little outline of what we're going to be talking about, I'm going to review where we stand with ovarian cancer in 2020, some challenges and considerations as we conduct research. I'm going to talk a little bit about upfront treatment and specifically advances in surgical management and adjuvant or post-operative treatment. Maintenance therapy is a very hot topic, which I'll get into a little bit. We'll talk about recurrent disease and the ongoing debate for the role of surgery there, as well as advances in systemic treatment or medical treatment. I do want to highlight a couple novel concepts that have recently come up, and then another thing that's near and dear to my heart is prevention. So where are we in 2020 with ovarian cancer in the United States? Well, it is predicted that this year we'll have 21,750 new cases of ovarian cancer. I've included the numbers for uterine cancer here because I think it's important to mention that there are about 3 times as many new diagnoses of uterine cancer in the United States as there are ovarian cancer. However, if you look down on the screen here, unfortunately, you'll see that there are still more deaths related to ovarian cancer, with ovarian cancer being the 5th most common cause of cancer-related death in women in the United States. So a little bit about the disease. Ovarian cancer affects about 1.5% of the general female population. That risk is higher in patients with a family history or who carry a genetic mutation. There is unfortunately still in 2020 no screening or early detection test. And as many people know all too well, there are no or at best minimum symptoms of early stage disease. And therefore, the majority of patients present when the disease has already spread outside the gynecologic tract and can be more difficult to treat. So we need novel treatments, and we absolutely need to focus on prevention. Ovarian cancer is not just one disease. Even when we divide it up into the main categories of epithelial or non-epithelial ovarian cancer, within epithelial, which is the most common type, there are multiple different subtypes, and this table lists some of them. There is the high-grade serous subtype, which is the most common subtype and is the kind that is associated with the BRCA mutations. There are other subtypes, such as clear cell and endometrioid carcinoma, which are more often diagnosed at an early stage than high-grade serous is, but not always. These types can be associated with the genetic syndrome Lynch syndrome and can be associated with the benign condition endometriosis. Mucinous carcinoma and low-grade serous carcinoma are other rarer types of epithelial ovarian cancer. So as we study this disease, we need to take into account that it's not necessarily one size fits all. Another important thing to discuss before we talk about clinical trials and research is the importance of clinical trial outcomes. So how do we measure whether a trial is positive or negative? How do we measure whether that new therapy or intervention is working? There are a number of different objective measures that we use. We use response rate, which is the response to a treatment. Does the cancer shrink? We use the concept of healthy time, which is progression-free survival or treatment-free interval. You can also think about this as measuring remission. Of course, overall survival or all time that a patient has is a very important outcome. And then quality of time. And within this, we look at health-related quality of life and patient-reported outcomes. And the questions sometimes are more complex than we think to answer. What do we value the most? What measure is the most useful? Which measure is the one that can get us ahead to better treatments the fastest? This table here comes from a very nice paper that was published in Gynecologic Oncology in 2014, really evaluating the pros and the cons of using these different endpoints. And I've highlighted both progression-free survival and overall survival on this table. Both of these endpoints, which have been deemed to be some of the most important, require a rigorous trial design. And importantly to note, overall survival is impacted not just by the drug being studied, but by all the different treatments that a patient may receive during her lifetime or her time with the cancer. And it does take a long time to answer. And so what we find is that as patients are living longer, it takes so long to get these overall survival metrics that science has already moved on. And so progression-free survival, you'll hear a lot about throughout my talk. What do patients want? And we have to ask patients what they want when we're evaluating the risks and benefits of a new treatment. This is a photo of Laura Haverleski. Dr. Haverleski is a gynecologic oncologist at Duke who has done extensive work looking at patient preferences. And I've just highlighted a couple things just to sort of set the stage as we talk about these therapies. She published recently actually looking at patients' preferences with regard to surgery first or chemotherapy first in the upfront diagnosis of a cancer. And she found that patients are willing to accept a higher rate of surgical complications, actually a 15% increased risk of surgical complications, and even an increased risk of postoperative death. And she found that patients were willing to accept a 4% increased risk of postoperative death in exchange for a survival benefit of 3 to 3.5 years. In terms of maintenance therapies like PARP inhibitors, which I'll talk about more later in the talk, patients were willing to tolerate the side effects of PARP inhibitors and even the small risk of myelodysplastic syndrome and leukemia for the clinically observed progression-free survival benefit that we're seeing in the trials. And then when we talk about therapy for recurrence, Dr. Haverleski found that progression-free survival or sort of time before the cancer grows really was driving the choice more so than symptoms of cancer or side effects. However, patients were willing to trade some progression-free survival time for significant reductions in treatment toxicity. So these are very important things to consider as we discuss the outcomes of some recent research. So getting right into that, talking a little bit about upfront treatment. This is what we used to have. So when I was a resident, and even when I was in the beginning of my fellowship, we had debulking surgery, which is surgery to remove the visible tumors in the abdomen and pelvis. And then we had platinum taxane-based chemotherapy, so carboplatin, cisplatin, and paclitaxel-based therapy. Well, now the landscape has gotten much more complicated, and we're seeing better outcomes because of it. Certainly debulking surgery is still very important, but now sometimes it comes first and sometimes we switch the order and debulking surgery comes after platinum taxane-based chemotherapy. The goal of debulking surgery has gone from optimal, which was not leaving any piece of tissue greater than 1 centimeter, to complete resection of disease. We're using things like HIPEC, which I'll talk about later, in the operating room. We have targeted agents like bevacizumab that we're adding to chemotherapy. And then we have this whole concept of maintenance therapy, which is given after treatment is complete to extend remission. So moving on to a topic that's near and dear to my heart, when a patient is diagnosed with ovarian cancer, what is the best first treatment? Is it surgery, which we would call primary debulking, or is it chemotherapy, which we would call neoadjuvant chemotherapy, followed by an interval debulking after several cycles? This table is a little overwhelming, but I just put it on here because this is a summary of the major randomized controlled trials that have tried to answer this question, which is best. And the majority of these trials came down with the conclusion that both options are good and comparable, and that neoadjuvant chemotherapy before surgery resulted in comparable outcomes. However, we do still offer surgery first to select patients. And the question may come up, well, why? If you can give chemo first and shrink the disease, why would you ever do surgery first? And part of the reason is that despite these trials being rigorous in design, unfortunately, the outcomes, meaning the survivals and the progression-free survivals, were much, much lower than we see here in the United States. Most of these trials were done in other countries in Europe and in Japan. So we have better outcomes here, and in many cases here, we have a bias towards surgery. The other thing that I point out is that in these trials, they noted that the average time of surgery was about 2 hours, and that is far less than the 6 to 8 to sometimes even 10-hour operations we do here in the setting of new disease. And so again, whereas neoadjuvant chemotherapy is a wonderful option, and we actually give it at Sloan Kettering in about half of our patients, it is important to sort of look into the details of these studies to understand what the right choice is for any particular patient. What we do know from these trials is that no matter when surgery is done, before chemo or in the middle of chemo or even after chemo, that the impact of residual disease persists in every single trial that has ever been published. So the surgery is complete, how much tumor is left in the abdomen? In cases where all the visible tumor is resected, across the board in every trial, those are the patients who had the best outcomes. And so this really leads us to sort of hammer home the conclusion that surgical effort and surgical quality absolutely matters for our patients. And being able to provide safe and effective surgery should be a continued goal of all ovarian cancer research. So what about heated intraperitoneal chemotherapy? Patients may have heard about this. This is the concept that patients undergo a debulking operation, and then at the end of the operation, a chemotherapy bath of heated chemotherapy is delivered directly into the abdomen. The theory behind this is that heat increases the penetration of the drug into the tissues, and that heat actually makes the cancer cells more sensitive to the chemotherapy treatment by impairing the DNA repair of those cancer cells. And then there are also theories that heat can induce cell death, activate heat shock proteins, inhibit the growth of new blood cells, and may actually kill the cancer cells itself by denaturing proteins. So this all sounds great, but we, of course, need to prove this. So in 2018, the results of a randomized control trial looking at this question of heated intraperitoneal chemo at the time of interval debulking, so after neoadjuvant chemotherapy, 3 cycles of standard chemo in the vein, patients go to the operating room, they have their debulking surgery, and then this heated chemo bath is performed. 245 patients were randomized, and what they found was that recurrence-free, which is similar to progression-free survival, was improved from 10.7 to 14.2 months in patients who got the HIPEC, and overall survival was improved 33.9 months to 45.7 months. So this was quite striking. They noticed that adverse events were similar. So we have started offering HIPEC at the time of interval debulking here at MSK after this paper. So moving on to sort of non-surgical treatments, people always are interested in immune therapy, and we are too. And so how do we use this, and what is the data about immune therapy and upfront treatment? The data on this trial was actually just released, I don't even think it's published yet, of looking at a drug called atezolizumab, which is a monoclonal antibody that binds to and inhibits something called PD-L1. Basically what this does is it unmasks the cancer cells. It unmasks the cancer cells so that the body's own immune cells can see the cancer cells and attack them. It's also called a checkpoint inhibitor. And in this trial, patients were randomized to regular chemo with Avastin, plus or minus this atezolizumab or placebo. And unfortunately, this trial failed to show any benefit with the addition of this immune therapy. But we have not given up, and there's another trial that has not yet been reported called the DUO trial, looking at carbotaxol and bevacizumab plus another drug or placebo. And so the arms of this trial are the durvalumab PD-L1 inhibitor, a PARP inhibitor, the combination of the two, or placebo. And the theory is that maybe the immune therapy didn't work by itself, but maybe if we combine it with a PARP inhibitor, which I'm going to talk about next, we will see synergy and better effects. So getting into PARP inhibitors, I guess it's important to explain what a PARP is. So a PARP is an enzyme that participates in repair of DNA breaks. So when you inhibit the patient's own PARP enzymes, you inhibit the repair of DNA breaks. In a patient with cancer who's receiving chemotherapy, and the chemotherapy is actively damaging the cells, if you also inhibit the PARP, you will inhibit the cancer cell's ability to repair that damage. So it's almost like a 2-hit. The chemo's 1 hit and the PARP inhibitor's another hit. And what we found is that especially in patients who have mutations like BRCA or patients who have BRCA-like cancers, that there are amazing effects that we've seen from these PARP inhibitors. This data has been probably the most exciting thing in ovarian cancer that I've seen in my career. This is the SOLO-1 data that was presented in 2018, looking at patients with BRCA mutations who were randomized to receive either a PARP inhibitor or a placebo after their completion of treatment. And you can see here this survival curve. The blue line is people who got PARP inhibitor, and the red line is people who got placebo. There was a 70% lower risk of death or progression of disease in patients who got the PARP. So this has really just changed everything. Before I mention some of the most recent trials, I wanted to mention another maintenance agent called bevacizumab. Bevacizumab is not a chemotherapy, but it is in fact a targeted agent that inhibits a compound called vascular endothelial growth factor. VEGF is a protein in the body that helps to create and generate new blood supply. So by blocking VEGF, and tumors have a lot of VEGF because tumors like to grow a lot of blood supplies to support themselves. By blocking VEGF, we can also block the growth of the tumor's blood supply, and in some cases stabilize or shrink the tumors. So this slide, which I know has a lot of words, I'm going to break it down, but this slide shows some of the most recent data looking at maintenance therapies like PARP inhibitor and bevacizumab. And this has all been presented and released very recently in the past 6 months in some cases. We have the POLA-1 study, which looked at chemotherapy plus bevacizumab, followed by bevacizumab, and they looked at the addition of a PARP or not. There was a significant benefit in the patients who got the PARP inhibitor. It was mostly in the patients that are HRD positive. This is code for the BRCA mutated patients or BRCA-like patients. The PRIMA study looked at chemo followed by PARP versus placebo. Also a significant benefit in progression-free survival, with the most significant in the BRCA and BRCA-like patients. And then we have VELIA, which was chemo plus PARP or placebo, followed by PARP or placebo. And they found, again, a significant benefit in the PARP arm plus the PARP maintenance arm for patients with a BRCA mutation. So this has really changed a lot for our patients, both those with BRCA mutations and BRCA-like mutation tumors, and even those without. So this has led to a lot of FDA approvals for frontline maintenance. So olaparib is approved as a frontline maintenance for patients with BRCA mutations or BRCA-like cancers. Olaparib in combination with bevacizumab has been approved. Bevacizumab alone has been approved as a maintenance option. This can be a really good option for patients who don't have a BRCA mutation, who might not be able to look to the PARP with as much hope. And then niraparib has also been approved. Other PARPs being studied are rucaparib and veliparib, which have not yet been approved in the frontline setting. So moving on to treatment for recurrent disease, talk a little bit about what we call platinum-sensitive disease first. So this is patients who have had at least 6 months of remission since their last platinum. And we consider that what we call platinum-sensitive, meaning we think that the platinum-based treatment may work again. The results of GOG 213 have recently come out. GOG 213 is a study looking at platinum-sensitive recurrences in women with ovarian cancer. This was essentially 2 questions wrapped up in one study. The first question looked at patients who had a recurrence of their cancer who were not candidates for a second attempt at surgical debulking. And those patients were randomized to receive regular chemotherapy, carboplatin and Taxol, or carboplatin, Taxol, bevacizumab, followed by maintenance bevacizumab. And this was really asking the question, what is the role of bevacizumab in the treatment of platinum-sensitive recurrence? And they found that bevacizumab did improve the overall survival to 42 months from 37 months in this group. So this is a commonly used regimen for patients with recurrence. The second question that was asked is, what is the role of surgery? And so if patients were deemed surgical candidates by their primary doctor, and there were no more specific criteria than this, they were randomized to surgery or no surgery. And interestingly, what they found, and sort of sadly to me as a surgeon, was that while surgery was a safe option, it did not improve outcomes over patients that just received chemotherapy alone. So there are some concerns with this study, and thankfully we have another set of studies that we can look for to look at the question of surgery in recurrent ovarian cancer. And this photo is of Professor Andreas Dubois, who is a personal role model of mine and a friend. And he really put together the desktop series out of Europe, excuse me, which was a series of 3 different trials, desktop 1, 2, and 3, looking to really rigorously set the stage for a trial looking at surgery in recurrent ovarian cancer. Desktop 1 was to establish the goal of surgery for recurrent disease and establish criteria for recurrent disease. Desktop 2 wanted to then validate those criteria and describe outcomes. And then desktop 3 was a randomized trial, which is really the gold standard for answering any of these questions. So desktop 1, which the results are here, showed that when patients with recurrent disease had surgery and the surgery was able to get all the cancer out, they had much improved outcomes. And you can see that here with an overall survival of 45 months. They established criteria, which include performance status, what happened after the first surgery, and the presence of ascites or fluid in the abdomen. And then in the validation, they found that using these criteria to choose whether a patient is a good candidate for surgery at the time of recurrence, they found that these criteria could predict who was likely to be in this blue line, so who was most likely to have successful surgery in 2 to 3 out of patients, which is pretty good. So then moving on to desktop 3, which was the results of which were just presented at ASCO. This was the randomized trial of patients who met these criteria for surgery, and they were randomized to surgery or no surgery, similar to 213, except with much more rigorous surgical quality control and much more rigorous selection criteria. And they found a significant difference both in progression-free and overall survival in the group that got surgery. So the remissions were longer and the overall survival was longer. So here at Sloan Kettering, we absolutely do surgery for recurrent disease, both at the time of first recurrence and sometimes even at 3rd or 4th recurrence, if a patient is a good candidate. And we look at our own criteria, which are how long the patient has been free of disease and free from platinum, how many sites of recurrence there are, whether there are multiple recurrence sites or carcinomatosis. And using this, we've had very good outcomes in our patients who've had surgery for recurrence. Just briefly to talk about PARP inhibitors in recurrent disease, there are many, many trials looking at PARP inhibitors, both in platinum-sensitive recurrences and in platinum-resistant recurrences. Platinum resistance, meaning the disease recurs within 6 months of the last platinum, recurs or progresses. And basically what we see is that, again, PARP inhibitors are effective at prolonging recurrences, and this is most profound in patients with BRCA mutations or with BRCA-like tumors. So moving on to some updates in the treatment of recurrent disease, platinum resistant. My disclosure here is that as a surgeon, I don't give these drugs very often, even though I do feel like I am capable of speaking on them. I cannot get into the minutia of some of them, but this is a very exciting new drug. This is called an ATR inhibitor, and the name of it is berzosertib, and I'm not even sure if I pronounced that right. But ATR inhibitors interfere with the ability of cells to detect DNA damage. So if there's damage to the DNA and the cells can't identify that there's been damage, then they can't repair that damage and the cells then die or become less viable. So there was recently a phase 2 trial of this ATR inhibitor plus a standard chemotherapy, gemcitabine. And what they found, and this was just published this year in Lancet Oncology, is that this combination significantly improved progression-free survival, and that there was some toxicity, but that it was reasonable. It was mostly anemia and decreased blood counts. So the question with the ATR inhibitors is, can this new class of drugs, could we possibly overcome the resistance to the platinum or even the resistance to the PARP inhibitors and sort of resensitize cancer cells to these new treatments. Another new class of drugs are the WEE1 kinase inhibitors. And similar to the last drug that I mentioned, these are also thought to increase the sensitivity to chemotherapy. So what the WEE1 kinase inhibitors do is they actually will make the cancer genome unstable. And by making the cancer genome unstable, they then make it more susceptible to the DNA damage that the chemotherapy causes. And there are currently phase 2 studies looking at these WEE1 kinase inhibitors in combination with chemotherapy to see if there's a synergistic effect here. Other kinds of immune trials. People, again, always ask about immune therapy, and it is a very exciting topic. And for some diseases like melanoma, it has been absolutely practice changing. We have seen some promising results in single agent studies with immune therapy. So some single agent studies have shown a response rate to checkpoint inhibitors of up to 20%. Now, again, just going back to the slide where we talk about outcomes, response rate doesn't necessarily mean remission, doesn't necessarily mean prolonged survival, but we have seen some responses. There have been some disappointments. So Javelin 200 was recently published that was looking at an immune checkpoint inhibitor in combination with a chemotherapy. And unfortunately, the interim analysis demonstrated futility, and so that trial was stopped early. However, we do have some ongoing reason for hope, and this photo here is of one of my favorite medical oncologists at Sloan Kettering, Dr. Dimitri Zamarin, who recently published in JCO just within the past couple months. JCO is a very prominent journal. The results of a study looking at nivolumab versus ipilimumab and nivolumab in recurrent platinum-resistant ovarian cancer, and found that the combination of these two drugs together resulted in superior response and longer PFS. So maybe that we have been mistakenly looking at single immune agents when really the answer is looking at combinations of drugs. So these are ongoing questions. So for my last few moments, I want to bring up some novel concepts and some things that I'm excited about. This study was recently presented in 2020 by this woman here, Kala Visvanathan, who was actually a colleague of mine when I worked at Hopkins. This was a study looking at statins. Statins are generally used to lower cholesterol, and many people take them as prescribed by their primary care doctors for high cholesterol. Dr. Visvanathan looked at the Finnish National Cancer Registry. So in Finland, with the National Health System, they keep very detailed records on health, and so these studies are able to be done, which is great. They looked at 10,000 women over a 20-year period with ovarian cancer in Finland, and they found, looking backwards, that the use of any statin was associated with a 40% reduction in ovarian cancer mortality compared to those patients who never used statins. So this is very exciting, but I think I would just caution that this leads to more questions potentially than answers. Whenever we look backwards at a cohort like this, we have to ask ourselves the question, is it possible that the patients who were on statins were in better overall health? Did they have better relationships with their primary care doctor? Were they getting more attention to their problems? Or was there some other genetic link between high cholesterol and doing well with ovarian cancer? So I think there are more questions that need to be asked about why this is. However, it is very exciting that potentially statins really do have an anti-cancer effect, and they are the subject of ongoing trials. Something that is near and dear to my heart and is the focus of a trial that we are trying to get off the ground right now at Sloan Kettering is the impact of surgical stress. So we know that while surgery is one of the most important aspects in ovarian cancer care, that the stress of a surgical procedure can also have some negative effects. So we know that stress can increase some factors that can lead to cancer growth and spread. I think overall the net effect is a benefit, but can we mitigate this stress? Can we try to decrease stress at the time of surgery for ovarian cancer and therefore harness the patient's immune system earlier on? And so what we're looking at Sloan Kettering is a perioperative stress reduction bundle using drugs like beta blockers that can lower heart rate and blood pressure, and we know have stress reducing effects, different medications like COX-2 inhibitors, modifying anesthesia to keep the patient's stress level low while they're under anesthesia, and then also using pre and post-operative integrative medicine like mind-body relaxation and acupuncture. And we hypothesize that by doing all of these interventions at the time of surgery, that we will decrease those negative effects of surgical stress, and our net benefit of surgery will be even greater. Moving on to a few slides on prevention, it is important to identify genetic risk. So we know that up to 20% of ovarian cancer is inherited through gene mutations. And we know that if we identified every woman with a predisposing mutation, we could prevent up to 4,000 or more cases of ovarian cancer in the United States every year. This is a huge reduction in disease burden. It's a huge reduction in suffering and death, in cost, and everything. So talking to your doctor about your family history, about genetic testing, and then talking to your family members about doing those same things is of the utmost importance, because while we don't have a screening test for ovarian cancer, we do have preventative strategies. As we're learning more about ovarian cancer, we have and I'm sort of skipping over the fallopian tube hypothesis because I think that's sort of old news at this point, but we do believe that while we have always called it ovarian cancer, that in fact it may be fallopian tube cancer, and that the cancer may start in the ends of the fallopian tube. And there are still a lot of unanswered questions about this hypothesis, but this new theory of precursor escape may be the answer. And what this describes, and this here is a picture of the end of the fallopian tube where the problem starts, but then the problem, or the precursor to the problem, escapes out of the fallopian tube early and implants on the ovary early, or it escapes out of the fallopian tube and implants in the peritoneal cavity. And this may explain why it's so hard to find an early detection test. There are those of us who believe that there may not even really be an early stage for the majority of patients who have high-grade serous ovarian cancer, because these little problems from the fallopian tube sort of escape and disseminate out so early. One point on a new development in genetics, we know there are a lot of mutations that are associated with ovarian cancer, the BRCA1, BRCA2, RAD51D, RAD51C, and BRIP1, but recently PALB2 has also established itself as being associated with an increased risk of developing ovarian cancer, with PALB2 carriers having up to a 5% risk over a course of a lifetime, which is much higher than the 1.4% risk in the general population, still much lower than the risk carried by BRCA mutation carriers. So how do we find the answers? And after all of this, that was a lot of information to digest in 40 minutes, but I wanted just to comment on this. How do we find out what's right for us? And Maggie brought this article to my attention. This was just in the New York Times, and the title of the article is "I Have Cancer Now My Facebook Feed is Full of Alternative Care Ads." So patients are finding that they put something on their social media status, and I'm not advocating for or against any particular social media platform, but people are finding that they'll put something on their Facebook status, and just like these social media platforms know what shoes you've recently looked at in terms of your online shopping, they see this too, and people are being targeted with these for-profit cancer cures, which in some cases can be upsetting and certainly could lead people down paths that might not be in their best interest. So as the opposite of that, I always tell my patients about the large number of really great and reliable resources that are out there on the internet. And I know Maggie mentioned the SHARE website, but this is just a screenshot that I took this morning. And it's the SHARE website with all these amazingly helpful links. I talked about a lot of GOG studies today. The WISP trial, I'm actually the site PI for the WISP trial here at MSK, so I'm excited to see that up there. There's a lot of great information out there, and but it can be very hard to find sometimes. A better kind of Facebook is also these survivor stories that are on the SHARE website, so I thought it was worth putting their faces up here. All of them shared powerful stories on the SHARE website, and they sort of are much better than these ads that we find in other aspects of the internet. And then finally, your team of doctors. So here at Sloan Kettering, we have the team OVARY, which is the ovarian cancer surgical team. That's me in the middle. And we are absolutely, committed to trying hard to be there for our patients and educate them when possible, do trials when possible, and of course, spend hours in the operating room. And finally, thank you to all the patients and their loved ones who make all of this work possible and worthwhile. So I'm happy to take questions.
Thank you, Dr. Long, for such an excellent presentation. You covered a lot of ground. So now we're going to start the Q&A. You can still submit questions in the question pane in the GoToWebinar control panel. We will try to get through all of the submitted questions, but we may not be able to due to time constraints. And good, I saw you put on your webcam. All right, so let's see what we have so far. All right, so you touched on HIPEC earlier, and this question is about that. Are there any factors that make a patient a good candidate for HIPEC with initial surgery, or that would rule it out for certain patients? Also, what about HIPEC during a surgery for recurrence?
So let me just make sure my slides are accessible here. Can you guys still see me or just my slides?
We can see both.
Okay, great. So, there are a lot of centers right now that are using HIPEC at various time points. So the time points that we think about are during primary debulking, before any chemotherapy is given, during interval debulking after a few cycles of IV chemotherapy is given, and then during surgery for recurrent disease. I would say that as an evidence-based purist, I would advocate for right now only using HIPEC at the time of interval debulking after neoadjuvant chemotherapy, because that is the only evidence-based time point, meaning that's the only time point that we have good research that states it's beneficial. We are doing HIPEC in some cases at the time of recurrence or at the time of primary debulking, but in the setting of a clinical trial, because the data has not yet shown, does not yet exist that that is helpful. In terms of who is a candidate for HIPEC, you have to be able to receive that chemotherapy drug. So if patients have an allergy to that drug or a prior toxicity that precludes them from getting it, they can't get it anywhere, including in the operating room. And then we do only give HIPEC to patients who are able to undergo an optimal resection of the tumor. So the surgical effort has to be successful first, and then the HIPEC can be given.
Okay, great, thank you. This next question is about statins, and it's asking if anyone is trying to study the use of them in the U.S. ovarian cancer population.
I do not have the specific trials, but there absolutely are trials going on that incorporate statins. as well as other commonly used drugs like metformin, which is commonly used as a diabetes medication. I can't point exactly to the direction of them, but they are being studied. I think the question the question really comes up as to at what point in a woman's lifespan does the use of the statin become relevant. So in that Finnish study, they looked at women who had ever taken a statin at any point in their life, not just women who received a statin during treatment. So we don't know yet even at what point to incorporate them, and so a lot of the research going on statins is also happening in the labs, so benchtop research and some preclinical research before we figure out which population of patients to give them to. You know, should we give them to BRCA positive patients who don't have ovarian cancer yet? Should we be combining them with chemo? I think there's a lot of questions that still need to be answered, but it is very exciting.
Great. Okay. All right. This next question is about low-grade serous disease, and if you could speak a little bit about any updates on that.
Yes. And you know what? I actually taking low-grade notes earlier because I figured somebody would be asking about that. Low-grade serous carcinoma is definitely a similar but different entity to high-grade serous carcinoma. It is much more rare, and therefore it is much harder to study. So because we have fewer patients, it's harder to do randomized controlled trials. One of the most exciting things that's happened with low-grade serous carcinoma is the incorporation of hormonal treatment actually to therapies. So we've found that in patients with low-grade serous carcinoma who undergo surgery and standard chemotherapy, that the addition of hormonal therapy, which in many cases is actually anti-hormone therapy, like an aromatase inhibitor that blocks estrogen, that we have had significantly improved results with that. We've had significantly improved results with that, and so incorporation of the aromatase inhibitors has become standard of care for patients with low-grade serous carcinoma after surgery. It is also being studied whether we can actually just substitute hormonal therapy with the aromatase inhibitor instead of chemotherapy altogether after surgery for patients with low-grade serous carcinoma. There was also a recent drug that was approved after data showed a benefit, trametinib, which is another one of these antibody-based therapies that showed a response for patients with low-grade serous carcinoma.
Great, thank you. So this next question is about PARP inhibitors, and if one of them fails, are others tried, or is it assumed that others would fail as well?
This is such a good question that this is the subject of some ongoing clinical trials, and the medical community has sort of a phrase for this. We call it PARP after PARP. So the main answer is that we don't know yet, but it is being studied, and in some cases, medical oncologists and gynecologic oncologists are trying different PARPs after one PARP has not worked. Another thing that we find is that as there are more drug options, there are times when patients may get a drug, that drug may stop working, they may switch to other therapies for a period of time, and then after time has passed, the previous drug that maybe didn't work before in some cases is being retried, and in that case, PARP inhibitors may have a role. It has been difficult though. PARP inhibitors are very expensive, and so we have run into some difficulty with insurance companies approving them if they're being used outside of these very strict indications.
Mm-hmm. And this is also about PARP inhibitors, but it's specifically for those who are BRCA negative, and if there's a best PARP inhibitor for that population.
Let me pull up my slide on the approvals. So it is always important to talk how how we talk about BRCA mutations is important. So patients can carry a BRCA mutation in all of their cells, in all of their blood and every cell in their body that they inherited from a parent and can pass along to a child. That's called a germline mutation, or a BRCA germline mutation, and here it's abbreviated gBRCA. We also know that BRCA mutations can occur in the cancer itself. So a patient doesn't have a BRCA mutation in all their cells, but at some point their tumor cells underwent a mutation, and the BRCA mutation developed in the tumor cells. And what we know, and that's called a somatic BRCA mutation. What we know is that both of those have had very good results with the PARP inhibitors. And so here you can see the different approvals. So olaparib is approved as first-line maintenance in patients with either a germline or a somatic. And then niraparib is actually approved for any patient with epithelial ovarian cancer mutation status independent as first line. And then there are similar, differing approvals based on the available data in the recurrent setting.
Okay, thank you.
It's really more based on not so much which PARP is the best, because there haven't been trials yet comparing one PARP to another, but it is who was included in the study that showed that PARP worked. And so that's how these approvals get made.
This question is about the SOLO3 trial, and this person said they were on the SOLO3 trial for 4 years, and they're doing great. And then last year, the trial researchers published data for progression-free survival, and they're still being followed. Is that because the researchers are now looking at overall survival?
Yes, absolutely. And in many cases, these trials will follow patients for years and years, because not only is the progression-free survival data important, but of course the overall survival data is important, but also long-term toxicities. So are there any, if we're curing more people with these drug therapies, we need to know what the long-term ramifications of them are. And we don't yet have data on what happens 10 to 20 years after someone takes a PARP. So these things are very important, and it's one of the reasons why these trials are so expensive too, because we have to put all these resources into the very important task of following patients long-term.
Okay, this question is about whether there are any new developments on the use of pazopanib for treating ovarian cancer.
Pazopanib is it is a drug that we use more commonly in other gynecologic cancers. We have not, based on the mechanism of the drug and the trials that have been done in the lab, it has not been something that we've used often in ovarian cancer, and so it's not a commonly researched drug either, but it has been very promising in some other gynecologic cancers.
Okay, and this person is asking about what are the typical side effects of PARP inhibitors, and whether you could touch on that a little bit.
Yeah, so just retouching on my disclosure that I'm a surgeon and I don't have as much face-to-face experiences as our medical oncologist at Sloan Kettering. However, the main side effects of a PARP inhibitor are GI side effects. So patients can have some nausea, some stomach upset, and some abdominal discomfort, especially at first when they're sort of getting used to the PARP inhibitor. Sometimes that can get better with time, or the dose can be adjusted. And then we also have to watch blood counts very carefully. So patients can have low platelets and low blood counts on PARP inhibitors, and sometimes the dose and the length of treatment needs to be adjusted for low counts. And then one thing that we're always paying attention to is there is a small risk, about 0.5 to 3% risk of long-term development of another type of cancer like leukemia or myelodysplastic syndrome with PARP inhibitors. And so as we're seeing more and more cures, that's something that we may find becomes more and more relevant.
Mm-hmm. Great. And so this person is asking about how do cross and RAD50 affect treatment options? And apologies if I'm saying that incorrectly.
It's okay. Was it KRAS?
Yeah, KRAS and
RAD50. RAD51. What was the RAD? What was
RAD50.
The RAD50. So again, you know, it's hard. We are in the era of precision medicine, and so we can look for both genetic signatures in a patient's bloodstream and in the tumors themselves. And so KRAS, for instance, I'm just pulling up here. So KRAS, we can often see associated with low-grade serous carcinoma and sometimes with mucinous carcinomas. That's where we most commonly see them, KRAS tumor mutations. Similarly with RAD50, that's not to be confused with RAD51D and RAD51C, which are germline or inherited mutations, which increase the risk of developing an ovarian cancer over a woman's lifetime and are indications for preventative surgery. So some of these genetics and genomics and the reports can get so confusing that it is very important for patients to have access to one of their doctors to go through both their blood genetic testing report and their tumor genetic testing report.
Mm-hmm. Okay, great, thank you. Okay, and this is a question, the one I sent you in advance, but I'll read the full thing for the audience so they have the context. So a woman called the ovarian cancer helpline recently and asked about S-Engine and the COC protocol. And, you know, the ovarian staff looked it up on the internet, and S-Engine is described as a way of testing cancer drugs against a patient's tumor sample to find out which are most effective and least toxic. The COC protocol is a combination of 4 medications used for other diseases. These include a statin and metformin and site studies in which they were observed to improve ovarian cancer outcomes. Is this pseudoscience, so sort of what is touched on in that New York Times article, or accepted by the gynecologic oncologists?
So I have never heard of either of those entities, and I very much appreciate you sending them to me ahead of time because I had time to ask one of our medical oncologists who prescribes all of these drugs and is also a rising star in the research community, and she had never heard of either of them. So I really can't comment specifically on those. However, what I would say is that science, real science and real medical research delivered to you by a doctor who really cares about your well-being is rarely something that will cost a lot of money and not have wide acceptance. So I do worry that there are a lot of for-profit companies, and again, I've not heard of these specific ones, but I do worry that there are a lot of for-profit companies that are marketing to patients with cancer who may be really understandably feeling desperate and trying to find sort of a magic bullet for their cancer. The first one that you talked about testing tumor cells to various therapies. This is a version of precision medicine, and precision medicine is something that should already be a part of routine care, specifically with genetics and genomics. The trouble with testing a cancer cell in a petri dish to see if a particular therapy works on it is that Cancers don't live in petri dishes, they live in human bodies, and drugs are metabolized through the liver, and there's a whole bunch of complex interactions that determine whether a particular therapy will work or not just what happened to a dish of cells or a little blob of tumor in the lab. So that would be my only concern with that first one. And the second one, which is looking at, I believe you said metformin, statins, and then I think there were some antibiotics in there, if I remember correctly. What I would say, that goes back to the statin data. I think that statin data that Dr. Visvanathan published is really exciting, but I don't know that we totally understand it yet to say that we should just start prescribing it to all of our patients. There's a lot of unknowns. And so while all those things have some sort of connection to science, I can't say that they're evidence-based, and I fear that they cost a lot of money out of pocket and that someone might be making a lot of money off of them. But again, disclosure, I'm not familiar with either of them.
Well, great. Thank you for responding to that question. I'm glad we were able to send that to you in advance so you could give it some thought. So shout out to Andrea, the Ovarian Helpline coordinator, for that, and also the New York Times article. So yeah, I think we're out of time, but I did want to share that, you know, we got some comments with people saying, thank you so much for this informative presentation, and you explained everything so clearly, and really, truly, thank you, Dr. Long. This was a great presentation, and thank you to everyone who joined and submitted their questions. We're really happy you participated in this webinar. And we just ask everyone to take a moment to fill out the survey at the end of the webinar. When we close everything out, it may take a minute for the survey to download, but then it should pop up on your screen. And that feedback is really important to us, and it helps us know what programming you'd like to see from SHARE. So thank you all, and thanks again, Dr. Long.
Yeah, thank you for everyone's attention. Hope everyone enjoys the nice day.